So we'll get going. I'll ask everyone to please mute your computer or your mic. I'm also going to do that here too. All right, so welcome to the poster session titled Taking Action, Health Intervention. And can you hear me clearly out there?
Yep.
All right, wonderful. So the poster session is titled Taking Action, Health Intervention, and we have 4 poster presentations for you. It's going to be a little awkward because I will be sharing the poster presentation and they will be telling me where to zoom in into the posters. So hopefully it's as smooth as we want to, but if there are any glitches, please be patient with us. This is the first time we're trying that. I do want to welcome everyone to this poster presentation. I am Gideon St. Helen. I'm an assistant professor in the Division of Cardiology at the General Hospital. And I mainly work on the clinical pharmacology of electronic cigarettes and cannabis products. A few housekeeping things. Again, I'll ask that all participants, if as much as possible, you keep your video on. And then please remain in the poster group until all the participants have presented or have had the opportunity to present their presentations. And we will take questions in the format of the Q&A. So just write your questions in the chat and I will monitor for any questions to the presenters. So the presenters will have about 5 minutes to present, and then we'll have about 5 minutes of questions and answer after each presentation. Okay, so our first presentation will be, first of all, let me make sure he's here. I'm not sure if he's here. But our first presentation is by Francisco Gomez Alvarado, and the title is Increasing Access to Medical or Psychiatric Evaluations for Asylum Applicants in the San Joaquin Valley. Francisco, are you here? I don't see him here. Okay, so we'll move on to the next presentation. Hopefully it joins in and then we could go back to him. The second poster is by Marlena Hartman-Filson, and it's poster number 43, and it's titled A Community-Based Tobacco Cessation Program for Individuals Experiencing Homelessness. And I will share your presentation for you. All right, can you see?
Yeah, thanks, Gideon. Can you hear me?
Yes, I can hear you clearly.
Okay, my internet has been a little bit unstable here, so just there's not much I can do about it. But I'll turn off my camera if you can't hear me. So hi, everyone. My name is Marlena Hartman-Filson. I'm a former clinical research coordinator at UCSF in the Division of General Internal Medicine. I am going to be presenting a poster entitled A Community-Based Tobacco Cessation Program for Individuals Experiencing Homelessness. And before I get into the weeds, because this was a community-based pilot, I wanted to acknowledge our community partners, especially Bayshore and Emmert-Aronson Navigation Centers, Alto Pharmacy, and the San Francisco Health Plan. I also want to acknowledge our funding source, which was SFCAN, the UCSF San Francisco Cancer Initiative, and the PI on this project, Dr. Maya Vijayaraghavan, who is a little square here. Hi, Maya. So a little bit of background, the prevalence of tobacco use is extremely high among people who are experiencing homelessness, about 70% compared to about 15% in the general population. It's the leading preventable cause of death in this population. And while people experiencing homelessness attempt to quit smoking at rates that are similar to those of the general population, their successful quit attempts are low. And part of this is because most of the quit attempts are unassisted in this population, and there are a lot of barriers to accessing cessation treatment. Even though there is a lot of evidence that shows that providing cessation treatment increases the efficacy of quit attempts. So our objective in this pilot was to assess the feasibility of a community-based pharmacy-linked program for smoking cessation for people experiencing homelessness. Our study took place between September 2019 and June 2021 and consisted of 3 phases. In phase 1, we trained 69 staff from 8 shelters across San Francisco on how to deliver brief smoking cessation counseling. In phase 2, we trained 2 staff members from 2 shelters, Bayshore and Embarcadero Navigation Centers, to become cessation champions. And in phase 3, we pilot tested a cessation program in those same 2 shelters that included number 1, a one-time pharmacist delivered cessation counseling session, and number 2, on-site access to nicotine replacement therapy for 12 weeks. We conducted 13 assessments for each participant. So at baseline, every week for 11 weeks, and then at 13 weeks, we had an exit interview. At these time points, we measured cigarette consumption, use of nicotine replacement therapy, any quit attempts, and encounters with shelter staff about smoking. For our analysis, we used Poisson regression to analyze weekly cigarette consumption and logistic regression to examine weekly quit attempts. And for all of this, we adjusted for age, gender, and baseline cigarette consumption. So we ended up enrolling 52 participants in this study, of whom 63% attended all 13 visits. 71% were male, about half were Black, and a majority used alcohol, meth, or cannabis in the past month. Median cigarettes per day was 8.5 cigarettes at baseline, and 75% of our participants smoked within 30 minutes of waking at baseline. We found that over the study period, 70% of participants did make quit attempts, and 84% reported actually using the nicotine replacement therapy that the pharmacy provided them. We found that the use of these nicotine replacement therapy products was associated with almost 3 times higher odds of making a quit attempt. We also found that engaging in conversations with shelter staff about smoking was associated with a 40% reduction in cigarette consumption, and using NRT was associated with a 22% reduction in consumption. As you can see in the figures down here, over the course of the study, average cigarettes per day dropped by 50% across all participants, and weekly quit attempts increased from 27% to 42%. So fewer cigarettes, more quit attempts. And in conclusion, we found that a smoking cessation program like this one that was linked with pharmacy-delivered community intervention was feasible to implement in settings like homeless shelters. And in addition to it being feasible, we found that it was capable of reducing tobacco use and increasing quit attempts among people experiencing homelessness. And what we take away from this is that community-based pharmacies can be leveraged to expand smoking cessation services in settings like homeless shelters. Of course, as it was a pilot, we had some limitations. The generalizability may be limited because we recruited from only 2 shelters in 1 city, and we had a fairly small sample size. Additionally, the data on smoking status and cigarette consumption was self-reported and not biochemically verified. And I can say that that was because the study took place almost entirely during the COVID pandemic. So we had like 2 months at the beginning that was pre-pandemic, but the rest of it was during the pandemic. So we weren't trying to use any breath tests for that. So that's what I've got. Thanks for listening. Happy to take any questions.
You did really well with timing. So does anyone have any questions? Please put in the chat. No questions.
I told you everything you could possibly need to know about this.
Can you talk a little bit more about what community-based pharmacies are and why you think they are important? Are they how important are they? What place can they have in the whole tobacco cessation, tobacco endgame?
Yeah, so the pharmacy that we used was Alto Pharmacy, and they deliver medications directly to their clients, and they also accept Medi-Cal. So that was really helpful for our study, and for this population in general. It's really challenging to go to different appointments. And in general, you can get nicotine replacement therapy for free if you have Medi-Cal, but that often involves like getting yourself to a doctor, and then it involves going from the doctor to the pharmacy, and you go to the pharmacy and they're like, we don't have your prescription, and then you have to go back. It's just like sort of a mess. And so for these populations where making appointments and transportation can be a real challenge, this can reduce some of the barriers to getting smoking cessation counseling service, because that can be delivered by the pharmacists on the phone, and then it can be delivered for free directly to the shelter. And in general, that was happening within a day. So that was pretty great.
That's good.
The other thing I will add to what Marlena just said, in the state of California, and there are several other states that do this, pharmacists can actually furnish an RT without needing a prescriber to prescribe these medications. So it actually does remove a significant barrier to people receiving cessation treatment in non-clinical sites. And it can be, applied to other co-linked problems with tobacco use, for example, substance use, opioid addiction, where they can also get buprenorphine. So you could think about combining interventions as well.
That's good. Any questions? Somebody said, I have a question, but it will take a minute to type. Please type your question. Okay, there we go. So she said, I am curious about how tobacco cessation as part of a broader effort to improve health in the unhoused population. For example, we know mental health and substance use, including tobacco co-worker. I'm wondering about how this could be part of a broader strategy to address health issues.
I think Maya started to answer a part of that. I think that's a really good question. And within this, I think is the shelters that we were working with are navigation centers, which is they try to have wraparound services and low barriers to access those and to have it on site. So some of these navigation centers have nurses, they have mental health providers, they have needle exchange. So all of these services are sort of being offered on site. And smoking cessation services have not been one of them at any of the shelters. And so I think that in some ways this was a missing link to the efforts to improve health for these populations within the shelter system, in that they are already making efforts to address some of the physical health and some of the mental health concerns. And so this fit in really nicely with their model of wraparound services, and it was not being used before. We can say that, so this study we did this as a pilot, but they are continuing the study as we speak. So they got funding for another year. I'm no longer with the team. I've moved on to graduate school, but that's sort of happening there. And I think they're looking at ways to integrate this with other, this smoking cessation program with other efforts in the shelters to improve overall well-being. I don't know if that answers your question.
That was good. Excellent. Okay, I think we'll move on to the next poster. And it's by June Tester. Just make sure that it comes up. Okay, here we go. So okay, here we go. So Joan's poster is entitled Recipe for Health, clinic-based approaches for food insecurity and chronic disease. June, take it away.
Yeah. So actually, and if you can maybe start by zooming in the left half and then we'll go to the right half. So my name is June Tester, and there are a large group of folks involved in this work. I am from UCSF and I'm part of the evaluation team along with colleagues from Stanford. Dig Deep Farms is actually the organization that provides food, and we work with Open Source Wellness, who conducts group medical visits. These are all with clinics within Community Health Center Network in Alameda County. And this is all a initiative of the All-In Anti-Poverty Initiative that's actually led by the supervisors of Alameda County. And the name of the project, the name of the name of our project is Recipe for Health. We know that chronic diseases, chronic health diseases affect BIPOC communities disproportionately. And our approach is that we are actually addressing food insecurity as one of many social determinants of health that we know affect vulnerable populations. This project, Recipe for Health, is very much ongoing. We started in January 2020. We are very much continuing. And what I'm presenting today is really just the sort of proverbial tip of the iceberg about people, participants who have gotten the highest level of intervention. People have gotten both food and group medical visits. Maybe next year we can talk about other participants who have different levels of engagement. Maybe scoot a little bit down in terms of methods. So patients in clinics in Alameda County are actually identified as being eligible for Recipe for Health, either because at a doctor visit, their provider feels that they would benefit and would be interested in actually participating in a group medical visit that would last 16 weekly sessions, and or they are identified because of a diagnosis of diabetes or hypertension or depression, or because in the absence of any of those diagnoses, they actually screen as food insecure using the 2-item screener that's actually part of the workflow for these clinics. So there are two main components, and actually pre-COVID, when this project was designed, it was based on a successful model where they had actually used vouchers for produce that were redeemed by patients on their way out the door in the waiting room in clinic. Obviously, with the pandemic, that had to be adapted. And so our model is actually now doorstep delivery from Dig Deep Farms to participant households for 16 weeks. Maybe scoot up to the next column. The other component of the intervention is group visits. And back in the day, people would show up in person to their other participants in group and exercise together, cook together, do mindfulness together. And obviously this all had to be adapted as well. So it is actually now a completely Zoom-based group medical intervention run by Open Source Wellness for 16 sessions. To speak a bit about the analysis, participants that go to those groups actually do self-report survey questions every month. And that data, that longitudinal data, is handled with mixed models. We also, though, to be able to kind of contextualize our work with other trends, actually look at it in other simple methods using chi-square from pre-post. So we'll talk a bit about the food insecurity data that way. We actually are, as I hinted at, collecting other data as well for people who just get food deliveries. And that's actually, that data collection is ongoing right now. So to date, for results, well over 1,000 people at this point in time have actually participated in the food pharmacy and in the program as a whole. Actually, about 1/10 of them have been in the higher touch level, meaning that they're participating in the groups in addition. The numbers here on this poster are pretty stable, have been pretty stable over time. This is just a snapshot from the abstract where at that point in time, we had 41 people with available data in the group medical visits. The participants reflect the overall patient population. This is largely Latinx and Spanish-speaking patients we're talking about. And to date, over 200,000 servings of fruits of produce have been delivered. Scoot up to the next column. So food insecurity, like the previous speaker, I mean, we can't take away the fact that these projects all have occurred during a pandemic. And just to put this in important context, the COVID impact survey showed that, basically food insecurity doubled nationwide from 12%, which is where it had been stably for several years, to 23% in those early months of the pandemic. And in contrast, actually, when we look at pre-post data from our patients in group, whereas 61% of them were food insecure using the 6-item food insecurity household security screener instead of the 2-item, 61% were food insecure, and actually 34% later. We are lifting boats here actually during hard times. Physical activity, health behavior data, looking at the monthly data collected from people in group, show that actually physical activity minutes per week increased by 43 minutes. And just to put this in context, 150 minutes of exercise per week is associated with concrete health benefit. Scoot up to the top of the next column. It's fruit and vegetable consumption. Combined fruit and vegetable consumption also increases over time in our participants, increased by 1.4 servings per day. And just to put that into context, one measly half-cup serving per day increase is also associated with a decrease in all-cause mortality and concrete health benefit. Depression is just one of several mental health outcomes that we look at. Obviously, you can anticipate that the benefits of being in a group format intervention during a pandemic absolutely is helpful for social isolation and loneliness, right? So those, we have other scores that look at anxiety and loneliness. Just as a snapshot here for the depression score, monthly data shows that actually over time participants' scores in terms of PHQ-9 also decrease. And actually, of course, those changes are more dramatic when you look specifically at people who are clinically depressed to start. So in conclusion, these preliminary data from self-reported health behaviors of people getting the highest level of intervention suggest improvement in food insecurity, in health behaviors and health outcomes, such as, for example, depression. Next steps, we're currently in 4 clinics. There will be 6 more in the next 2.5 years. This is very much ongoing work. And, I've spoken today just about people who are in the group plus getting food. We are also looking at people who just get food for 16 weeks. And with high level partnership with the county, we also have the ability to actually get health outcome data to be able to compare participants to non-participants in the wider EHR as well. We have gotten several sources of funding and beautiful drawings from Wilhelmina Perugin. And I think that's it for me for now.
Okay, great. We have time for just a few questions. Questions in the chat, please. So what's the ultimate goal of this recipe for health? What are you hoping to achieve? Is this something you're hoping to have like spread across the state, across the nation? What is the
high goal? You're asking what's the high goal? The high goal is an increased awareness of food as a covered benefit. So we have, a really unique partnership. I mean, this is not just academic folks. This is academic folks, farmers, and people in local government. And so actually our partners, such as, for example, Stephen Chen, are having meetings with actually, insurance companies and actually pushing for, adding support for, bills that go to the Senate for why food should be included, why food is medicine. Our previous name used to be called Food is Medicine. Recipe for Health is new branding, but sort of just a higher acknowledgement of food as a benefit, and also just an illustration of the benefit of social support. Obviously, we pivoted to be offering this by Zoom, but there have been benefits. Obviously, there are decreased barriers because of transportation for people to be able to access this support.
Excellent. Any questions from attendees?
Hi, Jen. This was a fantastic talk. I do a lot of food deserts research within vascular surgery and with the hopes of moving into food insecurity. So this is something that's near and dear to my heart. I just have a question about the depression aspect of this. Do you think the depression scores are likely to be seen when you are outside of the pandemic? I think you noted to the fact that like during the pandemic, a lot of like social cohesiveness has been impacted. Do you think these sort of trends that you see would be stable after the pandemic?
No, these are good questions, actually. And in fact, obviously, when we look at all of these measures during a pandemic, there's always a bit of nervousness about saying, are we even going to show that we're doing better? Or how about just let's aim for less worse? Right? These are hard times, right? Anxiety and depression are have been through the roof, right? And so it's an interesting question to sort of see, how this will change after the pandemic. I think that unfortunately, we're not out of the woods quite yet for any time soon. So these are interesting questions to look at.
June, can I add something?
Yeah. Hi, Ariana.
Hi, everyone. I work with June on this project, and I do a lot of research on group medical visit models, and you can just say there's other research showing that these kinds of models of care can be useful for depression. So I'm hopeful that that will continue to be true with this model too beyond the pandemic.
Excellent. So somebody has a question in the chat. Do you think your study participants are aware of food benefits? If not, is it a part of the study to inform them about food benefits?
Yeah, this is the limitations of having 5 minutes. This is actually a huge part of the intervention that I don't even have on here as well. When patients are at visit, they're screened for food insecurity, and there is a very large and very thoughtful algorithm for, especially when patients screen is positive for food insecurity at their medical visit. So the medical assistants and actually other staff take time actually to point people towards understanding. For example, many of these patients, for example, are undocumented and have high level of concern about accessing any benefit that might put them or their family in jeopardy. And so there's a lot of information to understand, help them understand that they can access food bank benefits without actually giving out their name or social security number. There's of course also SNAP enrollment process as well for connecting people to existing benefit. And in a way, actually, that is actually the standard of care, really, in terms of the clinic flow, right? This is a large kind of project for the clinics to be able to address need and vulnerability in their patient population and actually and meet that to resources in the community. These are sort of, getting food delivered to your doorstep for 16 weeks and participating in Zoom every week as well is a very high level intervention, but those are really important regular care aspects that we can improve for everybody.
Thank you so much, June. That was excellent, really interesting work. Let's go on. In the interest of time, we'll move on to the next talk by Katarina Wang.
Hello, hi everyone. My name is Katarina. I'm a research assistant with DreamLab and ARCH here at UCSF, and I'm currently a first-year medical student at University of Rochester. So today I'm going to be presenting on the patient count study, specifically the cancer supportive care needs and resource use among Asian American cancer patients. So to begin with some background, cancer is the leading cause of death for Asian Americans. Patient navigation has been shown to enhance cancer treatment outcomes and quality of life. However, the navigational needs of Asian American cancer patients in accessing cancer supportive care needs are understudied. Asian Americans face unique language and cultural barriers in cancer care. So an overview of our study, in order to better understand and address the needs of Asian American cancer patients, our team designed Patient Counts. Patient Counts is a culturally and linguistically tailored pilot patient navigation intervention. Our goal during the phase 1 pilot of Patient Counts was to examine cancer supportive care needs and resource use among Asian American cancer patients. In phase 2 and onwards, our goal has been to pilot a health technology intervention via an online patient portal to see how digital health can be applied to improving cancer care for Asian Americans. Today, I'm going to be presenting data from the phase 1 pilot of Patient Counts about the cancer supportive care needs and resource use. In terms of methods, we recruited Asian American adults diagnosed with stages 1 through 3, colorectal, liver, or lung cancer. Participants spoke English, Chinese, or Vietnamese and did not complete treatment before enrollment into counts. We recruited participants from the Greater Bay Area Cancer Registry and San Francisco hospitals. Our study sample was 24 participants. Participants were assigned a patient navigator who spoke their language. The navigator provided support and directed participants to resources for 6 months. Participants completed a survey at baseline, 3 months, and 6 months. Moving on to the needs assessment categories. In each survey, we asked for each participant's cancer care needs. Participants were asked to report if they would like resources or information in each of these categories: cancer information, daily living needs, nutrition and physical activity, language translation, access to healthcare, mental health, coping with side effects, and substance use. In the follow-up surveys at 3 and 6 months, we asked if participants utilize resources in daily living needs, language translation, access to healthcare, mental health, and substance use. Now I'm going to talk about our participants. If you scroll to the right a little bit, thank you. And majority of them were men. They tended to be older. Most participants did not speak English, and almost half of participants had less than a high school education. Participants had lung cancer, colorectal, or liver cancer stages 1 through 3. And lastly, 75% of participants started cancer treatment at baseline. Now I'm going to present our findings. Looking at the first graph on the left about needs reported, this graph is showing the number of different participants who indicated a need in the following categories at either the baseline, 3-month, or 6-month surveys. As you can see, there's a variety of different needs. Also, more than half of participants reported needs for cancer information, nutrition and physical activities, and language. In the second graph, if you scroll down a little bit, in the second graph, this is showing the number of participants who indicated a need for the following categories at the 3 different survey time points. In dark green is baseline, light green is 3 months, and light blue is 6 months. All the needs decreased over time except for mental health and healthcare access needs, which increased over time. And lastly, in the graph on the right, this graph is showing the number of different participants who utilized each of the following resources at 3 months or 6 months. More than half of participants utilized resources in healthcare access, daily living needs, and language. A minority reported using mental health resources. To summarize, the most frequently reported needs in our Asian American cancer patients were cancer information, nutrition and physical activities, language, and daily living needs. Next, we saw in our study sample that mental health and healthcare access needs increased over time. Lastly, the most frequently used resources were healthcare access, language, and daily living needs. In conclusion, there were a variety of cancer supportive care needs among the Asian American cancer patients in patient counts. It's important to continue assessing cancer supportive care needs in Asian Americans and providing navigation of resources. Our findings will inform future interventions to improve the care that Asian American cancer patients receive. And I just wanted to say thank you to our funder, Bristol Myers Squibb Foundation, our participants, and the Patient Advisory Council. Thank you so much.
Excellent. Any questions for Katarina? So I have a question. How do this, just looking at this Asian population, how do these results compare with maybe what you've seen among other populations in the US?
Yeah, that's a great question. So I think I would want to highlight the language translation need. That's a more unique need to this population. And also I want to highlight as well that in terms of our patient characteristics, a lot of folks in our study, had less than a high school education, and therefore a need at the forefront for them was daily living needs, which included like food, access resources, legal resources, financial resources. So I would highlight maybe those two.
Okay. Did you see any sex differences in the types of needs that you reported here? Any sex differences in your findings?
Since this is we're still in the earlier stages of the analysis, we have not seen or gotten to that yet, but that's a really good next step for us to investigate if there are any like gender differences in the needs.
Okay. I think June just asked a question. What are your thoughts about the increasing need for mental health services over time? How much of it might be worsening of the medical condition over time, perhaps, versus perhaps lowering of stigma about mental health access? Oh, great question.
Yeah, that's a great question. So there could be a lot of factors at play. We might be seeing an increase in need for like mental health, for example, towards the middle to end of the study, because maybe in the beginning, when we first enrolled these participants at the forefront of their minds was maybe like figuring out and navigating their treatment. And then like by 3 and 6 months, maybe like after they had gotten more clarity on that, the needs that were emerging more for them were like their mental health. And yeah, and I think, sorry, what was the second part of that question?
How much of it might be worsening of the medical condition over time versus perhaps lowering of stigma about mental health access?
Yes, and those two definitely are valid factors. Like there could be worsening of their side effects from their treatment, especially by 3 months and 6 months, worsening of condition. Also, you know, in Asian American cancer patients, there's a lot of stigma around cancer, especially within like the households. In some families, or if the grandparent has the cancer, sometimes their children will try to help manage their health, and there's a lot of dynamics going on. So I think those are all valid factors.
Good. So it's interesting that you brought up the stigma part, because we know that stigma likely varies across types of cancer. For example, smoking, lung cancer is, if you have lung cancer, you most likely were smoking, so it's your fault. So did you see any differences in terms of stigma across the different types of cancers that you looked at, like liver cancer versus lung cancer?
That's a great question. So our population is pretty small, or study population is pretty small, it's 24 participants. So we didn't necessarily see a difference, but that's something that definitely I'll look into.
Excellent. Any more questions? One more question before we move on to, I'm not sure if our next presenter is there, but.
Gideon, I think Ayana Bennett had a question in the chat as well, asking about the translation.
Sorry, I missed that, sorry. Was the translation need exclusive to language, or was cultural translation assessed in any way?
Thanks for that question. So in this case, I believe that the translation was mainly focused on language translation. But in terms of the cultural aspect, the navigator was, culturally and linguistically tailored to the patient. So the patients could have called the navigators, and the navigators could have provided some support, like from like a shared cultural understanding or background. But that wasn't necessarily assessed in our survey.
Excellent. Thank you so much. Really good work.
Thank you so much.
Let's see if Francisco is here. Francisco, are you here? So I don't see him here. So I guess if you have any questions for the previous 3 presenters, please feel free. Otherwise, we'll wrap it up.
Hi, I have another question for June, if you're still here. I think I missed this portion of your talk. I'm sure you described it, but just where are the patients coming from exactly? And like, how are you identifying them again?
Yeah.
Because you got a lot of people, and I'm just like, wow, like, how did that, like, is this a San Francisco general population, or is this, like UCSF? Yeah, thank you.
Yeah, absolutely. So they are all patients on the other side of the bay. So it's all Alameda County. And so these are FQHCs like Tiburcio Vasquez Health Center, for example, Lifelong Medical Center, Native American Health Center. And the list is growing. I mean, we keep adding more clinics within that CHCN network. These are, so they're all, Oakland, Alameda County, this side.
Thank you.
Any other questions? All right, well, thank you so much to the presenters and also to everyone who attended this poster presentation. Thank you very much.